Well, good morning, everybody. First of all, you have to pardon my voice. It probably sounds like 100 pack years. And if I lose coherence, I'm heavily drugged, but I think I can make it for the next half hour or so. So thank you very much for inviting me to give this lecture on what's basically the history of cardiac surgery. Although being invited to give a lecture on history is something of an ambivalent privilege, because it may mean that you yourself as the speaker are considered part of that history already. So it may well be true from my respect. All right, so let's go. Sorry about that. Gonna make it in the end. All right, so let's start with the definitions. So the title of that symposium is Congenital Shunt Lesions. I assumed when I got this title that we are talking about the left to right shunts, and looking at the program now, that is what it's going to be all about. And what I'm going to do is I spend about 10 minutes on patent ductus, then I'll spend about 10 minutes on atrial septal defect, 10 minutes on ventricular septal defect, about 10 seconds on the AV canal. And it's a bit imbalanced because in between we have to delve deep down into the development of the heart-lung machine, which is part of it all. So starting with the PDA, it's probably apt for a pediatric cardiac surgeon to start one's career with the first operation ever attended as a student was a PDA closure. There you can see me in 1981 in Oxford, England. And this, the gentleman you see on my right is Mr. Alf Gunning, who attempted and finally did close PDA in a 44-year-old Hong Kong Chinese woman. The more historic people in the audience will probably still remember the famous butterfly sign of the calcifications of the patent ductus, which you could diagnose on a plain chest X-ray. This operation ended up in a short segment replacement of the descending aorta under left heart bypass. So this is where it started for me. It actually started with a real birth way back in 1938, as you probably all know, with the historic operation by Robert Gross. He was at that time an aspiring young surgeon at the age of 33, and he did this operation famously when his chief wasn't in town, because William Ladd was against doing operations on the heart. He was, however, as is still the case today, heavily supported by the pediatric cardiologist, John Hubbard, who knew from Maud Abbott's experience that people with an open patent ductus have a limited life expectancy, not only because of congestive heart failure, but something that's almost forgotten today, mostly because of endocarditis. So when his chief was away, he operated on that 7-year-old girl. He did a planned ligation of a known patent ductus. He occluded it first, nothing happened. The circulation stabilized, and then he closed it with a single ligature. So this is really how it all started way back in 1938. It actually was a twin birth, as many people say. In the same year, way over here in Germany, in Düsseldorf, Emil Frey also closed a patent ductus. The exact date is unknown because the records were lost in World War II. His first assistant was Karl Voss-Schulte, another historic figure who became famous for his later treatment of coarctation of the aorta. They closed the patent ductus in a 14-year-old boy, but they didn't know he had a patent ductus, because the diagnosis when they went into the operation was an AV malformation of the lung. And then by chance, they discovered there wasn't an AV malformation, but there was a patent ductus, so they didn't know what to do. They occluded it for a little while with forceps, saw that nothing really much happened, and then decided to ligate it. So in the same year, the two first patent ductuses were closed, one in the US and one here in Germany. As is so often the case in surgery, you have a tremendous success, and then you start experiencing problems. The problem with a single ligature was that you could have a residual shunt, which was at that time detected not by echo but by auscultation. Don't forget about auscultation. But much more problematic was rupture. Gross himself lost his 12th patient, a 14-year-old girl, 2 weeks after the operation when she was enjoying her new life dancing because of rupture, because the ligature had actually cut through the maybe a little bit calcified ductus. So Robert Gross came up with a concept which is still valid today for an ordinary patent ductus, divided and oversaw both ends. Alfred Blalock at the Johns Hopkins Hospital in Baltimore came up with another idea for small children where he didn't feel comfortable of dividing a very short duct and recommended a triple ligature to divide the pressure on the ductal tissue. Further developments, as we all know today, if we still have to do a ductal ligation today, it's basically mostly in premature babies. And the first closure in a preemie, as they're called, was in a Negro female, a statement which is probably not politically correct anymore, in 1963 at the Mayo Clinic. And we should not forget that patent ductus was probably the first congenital lesions where actually the pediatric cardiologists took over the treatment from the surgeons who had started it all, because it was the group around Abe Rudolph in San Francisco who applied the principle of closure the patent ductus by inhibiting prostaglandin synthesis. And the theory that the ductus responds actually to prostaglandins was developed in 1973 at another, let's say, holy grail of pediatric cardiology at the Royal Sick Children's Hospital in Toronto by Cocciani and Olli. And in my opinion, the discovery of this mechanism is something that would well have earned a Nobel Prize, but never did. But even today, thousands of patients are only alive and do survive because we can manipulate the ductus by playing with the prostaglandins. And these two people are really unknown. So, well, I can take that time and drink some water. Don't know what happened there. Okay, so to come back to Oxford once more, it was actually Alf Gunning who in 1983 developed or described a simple, safe surgical technique for closing ducts in a preemie with a Liga clip. So it all came back to Oxford in the end. Okay, so much for the patent ductus. On to the next lesion, atrial septal defects. If you want to employ that obstetrical metaphor about birth of cardiac surgery, there were some things that you might call a premature labor. Because in the 50s, people like Murray and Bailey attempted to close, in a closed shop effort, atrial septal defects by invaginating atrial tissue into the defect and stitching it together. And if you look at these mutilated hearts, you may wonder yourself if it wouldn't have been better for those patients if you would have left the ASD alone. They must have all gotten into arrhythmias and whatnot. But those were the first attempts to really cure something inside the heart which you simply could not reach. What you may call a forceps delivery was developed by Robert Gross again. And he employed this ingenious contraption which he called an atrial well by suturing a funnel-shaped device onto the right atrium, then opening the right atrium, he let the blood come up, then felt the defect in the depth and then sort of sutured underwater like in a yellow submarine. So this was a bit more, let's say, pointed and targeted and better than those invagination techniques. Okay, on from the forceps delivery to what you may call a home delivery. It was Floyd Lewis in Minnesota who in 1952 for the first time closed an ASD under direct vision. And he employed the technique of systemic hypothermia, of surface hypothermia, which allowed him to decrease the metabolism of the patient and allowed him to rest the heart for a short period of time. His assistants at that operation were Richard Varco and Walton Lillehei. And remember those names, they'll come back in a short while. So the concept of hypothermia was that by decreasing body temperature, you actually decrease oxygen consumption, as we well know today, employing deep hypothermic circulatory arrest in complex lesions. But this enabled Lewis to arrest the heart for a short period of time. It was about 11 minutes or so. No, it was about 2 or 3 minutes, sorry, 2 or 3 minutes or so. And so he could see the defect and just suture it. Of course, the side effects of hypothermia were unknown at the time. So if we talk about systemic hypothermia and hypothermic experiments in Germany, especially in Berlin, our capital as it is again, this brings up bad memories in German doctors. Here you see two of our esteemed academical colleagues performing experiments on hypothermia in inmates of concentration camps. And they did this to develop better bomber jackets for the bomber pilots who flew over in the Blitzkrieg and bombed the United Kingdom. So always remember that not all doctors are saints, not even today. Hypothermia, however, continues to fascinate people because it's very hard for parents to understand that you actually cool down a patient, arrest the heart, and then can do tremendous things to it. So this was a headline in the Daily Mail, which is sort of the Bild Zeitung in England. Surgeon saved my baby's life by freezing her to death. Of course, it didn't die, and she survived and underwent a Norwood procedure. Well, so much for the first attempts. The first planned delivery, to stay with that metaphor again, was done famously by John Gibbon in Philadelphia, because he had developed the heart-lung machine and employed it for the first time in a human being after countless animal experiments on the 6th of May in 1953. So this enabled him to see the defect, and he assumed he had total control, which proved to be incorrect, as we will see in a short while. It took him 26 minutes and what he called constant suction, because it didn't arrest the heart, to see that defect and occlude it in the end with direct sutures. So this was John Gibbon who actually employed the heart-lung machine for the first time. And this is the machine, or the midwife, if you would like to call it that way. It's a tremendous apparatus. And this part here is the oxygenator, which was filled with 10 liters of donor blood. 10 liters of donor blood. And the steering contraption over there was actually developed by, at that time, rather small company called International Business Machines, which later on made their money with something else, as you all know. So this was the first heart-lung machine ever employed, needing 10 liters of blood. And this was 1953, and it didn't know much more than you had blood groups of AB, 0, and AB. And all the subgroups were unknown at the time. And you can imagine that problems were bound to follow. So the next 3 patients that Gibbon operated with that machine all died. They all had an ASD and they all died. And that was it for Gibbon. He said, I'm never going to touch a human being on the heart again. The machine isn't developed well enough. We have to stop our program, and he never did. So that was the end of heart surgery after a couple of months in Philadelphia. However, he had shown that the principle worked and that you could do it. So the lab research continued in three different places with the support of IBM. And it was John Kirkland at the Mayo Clinic in Rochester in 1955, and we'll come back to that in a minute, who started it anew. And in between 1953 and 1955, there was Walton Lillehei. Remember, he assisted Lewis in that first hypothermia ASD closure. He was a junior surgeon at the time. And he came up with the concept, we can do it without a machine. And we can do it in much smaller and much sicker patients who actually need it. And what he did, he tackled VSD, which brings us to the last lesion to talk about. So ventricular septal defect is a totally different kettle of fish because, as you all know, patients become very symptomatic very early in life from pulmonary hypertension. So the first attempts to tackle this disease were palliation rather than cure. And what Muller for the first time described in 1953 was the banding of the pulmonary artery. And if you look at this picture from the original publication, it's pretty much done the same way as we still do it today, although for different indications. So again, this concept, a palliative concept, goes back to 1952 because you couldn't think of any means to reach a VSD in the chambers of the heart. And in came Walton Lillehei. So on the 26th of March in 1953, he operated on a 13-month-old boy weighing 7 kilograms with a VSD with pulmonary hypertension in congestive heart failure. And he employed the concept of what became known as cross-circulation, which we ran for 19 minutes. And it's important to remember that he did this only after 2 failed attempts by Lewis employing hypothermia. So Lewis tried it twice to close a VSD under this systemic hypothermia, and both patients died. So this morally enabled Lillehei to come up with a principle which, again, he had developed in countless animal experiments. And the principle of the cross-circulation is that mom and dad are going to fix it, as they often do even later in life. And what they did is they hooked up the child to the circulation of one of the parents via the femoral vessels. So the deoxygenated blood was pumped with a controlled pump into the femoral vein of the parent, oxygenated by the ventilated parent. It came back via the femoral artery and then was pumped back into the aorta. And this enabled to sustain the circulation of the child for a certain amount of time, of course, mixing the blood of the patient with the blood of the child. And again, they did not know that this could cause hemorrhage. So this is the historic picture of the first ever operation under cross-circulation with Walton Lillehei in the center. If you look very closely, you see that he had a very strange neck. This was because he had undergone a neck dissection for lymphoma at the age of 28 and survived for a very long time. And if you want to read all about this, and I have many of the stories that I'm telling you from this book, it's the book King of Hearts, which describes the turbulent life of Walton Lillehei and is still available. So this is the first operation ever done under cross-circulation. It's Walton Lillehei here, it's Vaco there. And if you look at the innocent bystanders, they all became famous after all. So this is Vincent Gott, who ended up at the Johns Hopkins Hospital in Baltimore. This is Denton Cooley, who recently died. And look at him, look at the eyebrows. That's Aldo Castaneda. So they were all present at that first operation way back in 1954. Cross-circulation enabled surgery in younger patients because larger patients could not be supplied by a parent, obviously. It therefore enabled surgery in much more complex lesions, such as VSD, which needed an earlier treatment. Just forget about ASD, which you can treat any time in life. But it also enabled 200% mortality, which eventually happened because they did not know. And right from the start, the idea to employ this cross-circulation with that potential 200% mortality was under an immense moral debate in the hospital and outside. And it's brilliantly described in that book, King of Hearts. Interestingly enough, 30 years later, Walton Lillehei did what we now call a follow-up and looked at what happened to those patients. In that time, when he employed cross-circulation, he operated on 45 patients, 8 of which died in the hospital, including 2 of the parents. After 30 years, 17 of these patients, and they included VSDs, AV canals, and tetralogy of Fallot, basically, were still alive, which is, after all, a tremendous effort. But he knew that this was not the way to go with cross-circulation. In that article, he describes there were innumerable failures, disappointments, frustrations, and obstacles, nature's as well as man's. And the only solution was, and watch that, a mixture of persistence and stubbornness, which is something that they encounter in surgeons very often. But they knew you couldn't go this way forever. Now comes the detour into the heart-lung machine. The further development of the heart-lung machine followed 2 paths, if you will. The one was going to decrease that immense surface that you needed for oxygenation. I told you 10 liters, get it down to 5, get it down to 3. So the one concept was the downscaling of the surface area, which ended up in the grid oxygenator. A totally different concept was the development of what's called the Bubble-Oxygenator, where the oxygen had to provide its own surface. We took like a shower head and put it into the blood and blew the oxygen through the blood and then oxygenated the blood. The problem was what to do with the foam that resulted. And here you see Vincent Gott, later of Baltimore fame, with the first disposable defoamer. Here it's the blood that comes up here, and in that contraption, the blood was finally defoamed and could be pumped back into the patient. So this, in the end, allowed relatively easy manufacturing, serial manufacturing of disposable devices. And it led to serial production. They're actually still made in China because they're cheap to manufacture. And if you have an aquarium, they're still made for fish because this is what you do when you blow oxygen into your aquarium. So those were the bubble oxygenators. And you may know that although you could defoam the blood, as Vincent Gott so brilliantly showed, there were still microbubbles. And they cause problems mainly in the cerebral circulation. So the breakthrough finally came with the development of the membrane oxygenator. And as so often in medicine, the real breakthrough was achieved only when we were able to mimic nature. The lung functions with a semi-permeable membrane, and this is the concept which was finally developed. You have the blood on the one side, you have the gas on the other side, and a semi-permeable membrane allows the gas to go one way or the other, allows the oxygen to go in and allows the carbon dioxide, don't forget the carbon dioxide, to go out, which is just as important. So those were the first membrane oxygenators ever developed. And the technique that we're using today is basically the hollow-fibre oxygenators, which again are membrane oxygenators, only with the concept that the fibers are rolled together in very small hollow fibers, and they're all put to end. And this enables you to put a tremendous surface area into a very small volume. It's the principle of the toilet roll. But as you know, with the toilet roll, it still has its imponderabilities. So this is the end of the detour in the heart-lung machine, and this is basically where we are today. So what about VSD? VSD, the last development, if you wish, again came not surprised, oh no, sorry, what about VSD? Here we come. It was John Kirkland in Rochester who in 1955 employed that grid oxygenator that I showed you at the beginning with a smaller surface in Rochester at the Mayo Clinic. And again, imagine this today. The plan for the study plan was to operate on 8 patients, no matter the outcome. They would have operated on 8 patients even if 7 or 8 had died. This, fortunately enough, did not happen, but still, they had a 50% mortality in these 8 patients. And this 50% mortality sort of legitimated them to continue research and keep on going. Unimaginable today. And see, Walton Lillehei at the other end in Minneapolis operated 2 months later, employing the concept of the DeWaal-Lillehei Bubble-Oxygenator. So at the same time, grid oxygenator, bubble oxygenator, both in 1955, and from then, you may say cardiac surgery never stopped. It's interesting that the 2 cradles, to employ that birth metaphor again, were actually only 60 miles apart in Minnesota, one in Minneapolis and the other one at the Mayo Clinic in Rochester. Because both of those universities employed what John Mayer later described the creation of an intellectually open, supportive atmosphere for scientific inquiry in academic surgical departments, something that we should still strive for today. Scoffers say it was there because there's nothing much else to do. Half a year is winter, half a year it's cold, so you can be glad if you're down in the lab where it's warm. So much about Minnesota. And to round this up, the VSD, the next and, if you wish, last development in VSD, again, not surprisingly, came from Walton Lillehei. In 1957, he described for the first time the transatrial closure of what he called a posterior VSD. It was an 8-year-old girl with a pulmonary arterial pressure of 95/55 with an unknown, at that time, PDA and a posterior VSD of a diameter of 1.5 centimeters, which he closed transatrially by inverting the tricuspid valve, and then he employed 6 sutures tied over a pledget of compressed polyvinyl sponge. That's the way they did it. And he must have been an extremely dexterous surgeon because it only took him 11 minutes, which is hard to imagine. What's interesting from my point of view, because I'm the editor of a medical journal, is the publication. The publication meticulously describes first a set of animal experiments where they did right ventriculotomies in dogs and then looked after the Frank Starling mechanisms and looked how the right ventricular function was affected by a ventriculotomy. And they did a longitudinal one, they did a transverse one, and they did one in the infundibulum. And not surprisingly, they found that the infundibular incision was the best one. But in each of these types of ventriculotomy, they found right ventricular problems. And in that high-risk patients, they simply did not dare to cut into the ventricle, which had to, up to the time, had the labor of providing 95 millimeters of mercury of pressure. So they simply didn't dare and tried to do it transatrially. And in that publication, you first get the dog experiments with all the figures and all that, and then that single case report. And it's got 1, 2, 3 authors. If you look at scientific publications 60 years later, you probably would have like 10 authors here, and they would have broken it down into the least publishable unit. One paper about the longitudinal incision, one paper about the transverse incision, one paper about the infundibular incision, and then the case report. So that's 4 publications instead of 1. This is where we have come to in 60 years. And as far as the VSD is concerned, we still close 90% of them transatrially as described for the first time 61 years ago. So Walton Lillehei was really a very special character. Like many surgeons, he also had his problems, which you can read in his biography and which I won't go into here now. He summarized his general attitude as follows. Some see things as they are and ask, why change? Others dream of things that never were and ask, why not? And many surgeons are in that part. And to come back to that final thing, am I a part of history? To come back to that living legend thing, here's a final quote for you by someone who knows. The legend part is easy. It's the living that's hard. Thank you very much. Thank you very much.
Thank you, Herr Heinemann, for this